Welcome back, everyone. We're so fortunate to have this incredible panel of NET experts join us today for a live question and answer session. It's an honor for me to introduce today's participants, Dr. Osman Ahmed, interventional radiologist from University of Chicago, Dr. Kalicia Clark, surgical oncologist from Medical College of Wisconsin, Dr. Hidero Del Rivero from the National Cancer Institute in Bethesda, Maryland, Dr. Nadine Malak, radiologist and nuclear medicine physician from Oregon Health and Science University in Portland, Dr. Chandrika Chandrasekaran, medical oncologist from University of Iowa, Dr. Alexandra Ganji, surgical oncologist from Cedars-Sinai, and Dr. Thor Hafdanarsson from Mayo University in Rochester, Minnesota, and Dr. Eric Mitra from Oregon Health and Science University, as well as Josh Mailman, who is president of NorCar Calcinet and patient advocate extraordinaire, who will be serving as co-moderator for today's Q&A along with myself. So today's question and answer session will be divided in two parts. I will moderate the first part with Drs. Ahmed, Clark, Del Rivero, and Malik, and then Josh Mailman will moderate the second part with Dr. Chandrasekaran, Dr. Ganji, Hafdanarsson, and Eric Mitra. So the first question I'm going to start with is an interesting one, and Dr. Julie Haley mentioned alert bracelets and other alert devices. This is something that comes up commonly. It came up during the pandemic, but just out of curiosity, Dr. Del Rivero, we'll start with you. What type of information should a NET patient have on hand when a non-NET medical issue arises and a visit to the urgent care or ER is necessary?
Thank you so much for that question. It is an important question as well. I think that every patient who has a diagnosis of neuroendocrine tumors, it's important that there is a open communication with any treating physician, even if the patient goes to the emergency room. In terms of certain management, because one answer could be like if there is any extra that needs to be done in terms of the management of neuroendocrine tumors. And it also will depend whether the tumor is functional or non-functional, or whether there is any hormone deficiency as well. The tumor is functional, like, for example, a tumor that is producing insulinoma, any ER physician needs to be aware so that way they can take the appropriate measurements in order to prevent the glucose to go down. The same with any other hormone excess like gastrin. We know that gastrin stimulates the acid in the stomach. Sometimes when it's not very well controlled, it goes to the emergency room with pain, abdominal pain. I think they need to be aware and discuss the main or most important clinical characteristics of the neuroendocrine tumor. I have to say that the NET Vitals is a very good tool. LACNETS has this NET Vital who also tells you the different symptoms in terms of the diagnosis of neuroendocrine tumors. And I think that's important also to have in hand whenever there is an emergency and needs to for non-related NET issues. Another answer is like, well, in a patient with carcinoid syndrome, do I need to take an extra shot if there is any extra procedure? I don't think there is data on that, but that said, it would be important to make aware to the doctors that I have a neuroendocrine tumor, my neuroendocrine tumor is functional, so that way the physician is aware if any extra measurements needs to be done, depending on what other non-NET conditions the patient may have.
Thank you, Dr. Del Rivero. And Dr. Clark, I'd love to hear the surgery perspective.
I would really defer to the medical oncologist from a surgical standpoint, unless you're having an abdominal surgery for the most part that is going to sort of affect the amount of hormone that's being released into the venous system at the time. I think the overall risk is fairly low. Of course, taking into consideration the absence of more serious conditions like carcinoid heart syndrome, et cetera. But I think a really good anesthesiologist preoperatively needs to have a thorough history and physical exam to basically weigh your risk for any sedation and any general anesthetic for sure.
Thank you so much, Dr. Del Rivero and Dr. Clark. One of the most popular questions today, and I'll ask Dr. Del Rivero this, is what kind of research, if any, has been done into the cause of neuroendocrine tumors?
So what we know in terms of the causes of neuroendocrine tumors is that we don't really know the cause. That said, approximately 10% of patients that have neuroendocrine tumors may have a familial syndrome associated with the neuroendocrine tumors. Most of them is pancreas neuroendocrine tumors like von Hippel-Lindau, multiple endocrine neoplasm, neurofibromatosis, that they have neuroendocrine tumors as part of the group of clinical manifestations associated with the familial syndrome. And for that, there is now guidelines that help us understand what the surveillance is needed for each one of these familial syndromes. But what we know is that we really don't know the causes of neuroendocrine tumors. And we know that it has increased in incidence. That said, the incidence may be related because we have better diagnostic tools. We do more colonoscopy, more endoscopy. There is some what we call epigenetic changes, whether that could some small changes within the specific genes that may be one of the causes of neuroendocrine tumors. But that said, this is still an evolving area, and of course, a research question as well. One other question that comes from patients is like if there is any other environmental aspects that may put a patient at risk to develop neuroendocrine tumors, and that's not necessarily known. But that said, at the NIH, we have this natural history study that allows to follow patients over time. And we hope that we will able to answer those questions in terms of if there is any cause or if there is any other familial syndromes that we don't know that may predispose the patient to develop neuroendocrine tumors. That's a good question. But what we said in terms of the cause, we said that this is sporadic, so we don't really know the cause. But that said, there is an ongoing research that will help us hopefully to understand causes, and maybe with those causes, we can also work on some prevention measurements as well, but that's an evolving, field.
Thank you so much, Dr. Del Riviere. More work needs to be done. Dr. Malak, your presentation on scans last year, this year are so helpful. Regarding dotatate PET scan results, what is more important, avidity or growth? And a follow-up question was, what SUV max is a cause for concern?
So first, it's important to think of this setting we're doing the dotatate PET in. So if it is a staging for a well-differentiated tumor, then it's going to help us detect the site of metastatic disease. And for that, or if we're assessing before PRRT to see whether a patient qualifies for PRRT. So for that, we look at the SUV max and we look at the uptake in the tumor, because the higher the tumor takes up the agent, the higher the likelihood of response to PRRT is. So in that setting, the SUV max is an indicator of the differentiation of the disease. So how much somatostatin receptor does it express on its cell surface? And that's what we're targeting with imaging and with PRRT. So in that setting, the SUV max is very important. Now, when we're following up after treatment, that's a different setting. Because after treatment, so if the tumor, the SUV max goes up, it doesn't necessarily mean that the tumor is getting worse. So it just means it's expressing more the somatostatin receptor. It is not necessarily bad. And when the SUV max goes down, the tumor could be shrinking and responding, but also it could be getting de-differentiated. And so for that reason, the SUV max is not reliable for follow-up. And so that's a very important point in the interpretation of the response to treatment on dotatate PETs. So when we're assessing the change over time, we rely very much on the size of the lesion. Is it growing? Is it shrinking? And on dotatate PET, are there new lesions? So then the appearance of new lesions on dotatate PET is going to indicate that there are new sites of metastatic disease. But the SUV max, so it's not reliable to assess for response, and there is really like no level of concern with SUV max. So it's very different than other kinds of PET CTs, like for example the FDG PET, which indicates tumor metabolism. The higher the SUV max, the more concerned we are about the disease, that it's an aggressive one. That's not the case with dotatate PET.
Thank you so much, Dr. Malak, for your clarification. Dr. Clark, looking at the preparing for surgery, prior to surgery for a tumor localized to small bowel and pancreas suspicious for NETs, is a biopsy a must? And then if so, with a biopsy, is it FNA adequate? And then one more question is, would you always want a dotatate PET CT?
So in general, for small bowel neuroendocrine tumors, oftentimes you're unable to get a biopsy or an FNA. Unless the tumor is very close to the terminal ileum and they can access the tumor from a colonoscopy. It's actually quite rare that we get a tissue biopsy of a small bowel neuroendocrine tumor from an endoscopic procedure. Depending on the location of the lesion in the bowel, it may or may not be amenable to a needle biopsy because it may not be safe. There may not be a window through which they can stick a needle in to sample the tumor. So an FNA is certainly not always possible. A dotatate is often in this setting both diagnostic in that it can confirm a neuroendocrine pathology, which is, of course, I think very consistent with well-differentiated neuroendocrine tumors. It is also very informative in terms of staging. And so it's really important for us as surgeons, medical oncologists, radiation oncologists to have an adequate idea of how much volume of disease you have and exactly where that disease is located, so that as we figure out what treatment options we're going to utilize, and for me as a surgeon, what surgeries I'm going to perform, that I have the utmost confidence that I'm going to be able to remove all of the visible disease. So the short answer is FNA, not always feasible. Especially for small bowel lesions. A dotatate, for me, is always a part of the staging process and is very informative. For pancreatic neuroendocrine tumors, not all pancreatic neuroendocrine tumors need to be resected. So for small, non-functioning pancreatic neuroendocrine tumors, and we consider small to be those lesions at least less than 2 centimeters in size. We can watch some of those. We can observe them closely. We know that the majority of these tend to be benign and they tend not to misbehave or metastasize. And so for many of those patients, again, depending on size, for lesions that are less than 1 centimeter, it actually can be quite difficult for a biopsy to be performed because it's literally like a needle in a haystack when we look at the pancreas. But again, a dotatate here can be very helpful. And in general, because of where these tumors are located in the pancreas and the small bowel, if a biopsy is performed, we're often looking at an FNA and not a core.
Thank you so much, Dr. Clark. Dr. Oz, as you can understand, histotripsy has been very popular. There were like 5 questions that were combined into one. So when is histotripsy used? And thank you for covering it also in the tumor board and also in past presentations, which can be referred to. So just to kind of recap, when is histotripsy used? Can it be used as first line for people with NETs with small metastasis to the liver? Can it be used for high-grade liver mets? Also, there was another question of, does it matter if there's tumors outside the liver? Can it still be used for the liver? And how close is it being used to be treated for lung and pancreas NETs as well?
Yeah, great questions. You know, as you mentioned, I think histotripsy is super exciting technology. It is a relatively new technology in that it has recently been FDA approved, and we are fortunate that we're one of the sites that carries the technology. But you know, more and more centers, I feel like, are rapidly acquiring it. So, you know, just to take a quick step back, you know, from an interventional approach, we have 2 ways that we treat tumors typically. One is to go through the arteries and we deliver chemotherapy, bland embolization, bland beads, or even radiation beads through the arteries. And those are termed radioembolization, chemoembolization, bland embolization. The other form of therapy that we do is more targeted therapy, where we actually take a needle, put it into a tumor, and either burn or freeze it or even electrocute it. Histotripsy falls into that bucket, which is known as percutaneous ablation. What's different about histotripsy is that it is non-invasive. So it uses ultrasound energy to treat tumors. So you don't actually need to put a needle into the body. You can actually just do it from the outside and shoot those ultrasounds at the tumor. It is non-thermal, so it doesn't use heat or cold energy. So it tends to be a little bit safer, especially when tumors are close to critical structures like bile ducts and blood vessels. And it also doesn't use any radiation because it's all ultrasound based. It's a very attractive technology for that reason. So the first question really was, you know, can you use it as a first-line therapy? If we consider it as an ablation modality, we certainly can use it as a first-line treatment option, in the sense that we're going to be using it just like we would use percutaneous ablation. With that said, you know, it's a very new technology, so we don't have, you know, large studies that sort of tell us what to expect after you have a histotripsy. But for the reasons that we just mentioned, people are interested in even having that as a first-line treatment because it's even less invasive than percutaneous ablation. Now, for people who have maybe tumors that are not just in the liver, but outside of the liver, histotripsy also has some interest, which is not yet validated. There's not, great studies or anything like that yet. But one of its potential advantages is that it can actually create an immune effect. It can actually sort of stimulate the immune system to sort of potentially attack residual tumors or even tumors that are far away from the tumor that you're treating. And so there is some interest in that phenomenon, which is known as the abscopal effect, which was largely seen in animal studies with this technology. So I think as we evolve over time, we'll hopefully be doing studies to sort of investigate that. We're not really offering, at least I'm not really offering that as a standard of care treatment right now, but I think there's a lot of interest for that reason. And I think your final question was, can you use this technology outside of the liver? You certainly can. It's a platform technology, meaning it's not just specifically for the liver. It means there's a trial actually ongoing right now for kidney cancer. It's been described for use in the prostate. But where histotripsy seems to have issues, because it's ultrasound based, is it can be blocked by bone and gas. And so one of the issues of treating it even in the liver is that we have to work around the ribs or work under the ribs. And in the lung specifically, air is a gas. So tumors are surrounded by the lung or air. So really right now you can't use it in the lungs as well. So we look more towards the soft tissues.
That was very thorough. Thank you so much, Dr. Oz. And Dr. Del Rio, I'm so glad that we have an endocrinologist here today. This question was upvoted quite a bit. What can be done about problems associated with gaining weight, which are due to NETs, like hormonal imbalance, metabolic imbalance, or intolerance, insulin resistance? What would you say?
I think there is a few aspects here. So it's kind of like what we can do if there is weight gain, if there is any other what we call hormonal imbalances. So I think it's important to also recognize certain symptom specifics of conditions associated with neuroendocrine tumors. And by that, I mean, for example, lanreotide, octreotide, we know that it can cause hyperglycemia. It can cause the blood glucose to go up. And approximately 30% of patients that are on lanreotide or octreotide, the blood glucose can go up. And that's considered also an endocrine condition where these medications, octreotide and lanreotide, inhibit the release of insulin. So whenever we eat, the blood glucose go up, and then there is a release of insulin in order to lower the glucose. But since these medications can suppress the release of insulin, so then we have this risk of having elevated blood glucose. So it's important to recognize, it's important to check labs every 2-3 months. Patient may have follow-up labs. So it's important to also check the glucose as well, just to see whether it's maybe going up, because if it's going up, there may be certain measurements that can be done at the time. One other thing to recognize about endocrine abnormalities is that sometimes this lanreotide or octreotide can also affect the thyroid hormone. It's very rare, but it can happen. And patients are also taken like tyrosine kinase inhibitors. I'm sure there was a discussion about cabozantinib, lenvatinib, sunitinib. All those medications has a risk also to affect the thyroid hormones, and that means that the gland is not producing enough hormones, and that's considered a metabolic hormone. And I think it's important any patient that is on sandostatin, lanreotide, or patients are also on these tyrosine kinase inhibitors, so that the thyroid hormone is also checked. Because, as I say, the thyroid hormone is considered a metabolic hormone. If there is a deficiency of these thyroid hormones, then it's going to be associated with increased weight, fatigue, the hair becomes more thinner. So there are certain aspects of the medication itself that may cause endocrine abnormalities, not necessarily some of the tumors itself. We know that these neuroendocrine tumors can cause mainly pancreatic neuroendocrine tumors can cause excess of different hormones, but neuroendocrine tumor itself not necessarily may cause certain abnormalities. It's more some of the medications. That said, some of the pancreas neuroendocrine tumors, and maybe Dr. Clark can comment on, depending on how much pain is resected, the patient can become insulin dependent. So because the pancreas is not producing more insulin, that can also cause the risk of elevation of the blood glucose. And I think it's important to recognize as well all of those consequences that could be either for certain surgeries or as well for certain medications. It's important to recognize symptoms as well, and based on those symptoms, do the appropriate workup too. Endocrine tumors. One other thing is like there are certain chemotherapies as well that may also suppress the sex hormones too, like estrogen or testosterone, and those can also be associated with some weight changes, can place somebody maybe in early menopause, but that's something that needs to be aware as well of all these different treatments. But I would say it's more the treatment effect of the neuroendocrine tumors, that you may have these different endocrine abnormalities, but the most important is recognizing the symptoms. That way we can do the appropriate evaluation for those hormones.
Thank you. That's very helpful. And Dr. Clark, you're welcome to comment on this. And there's also another question about pancreatic net about, is enucleation a recommended treatment for small pancreatic nets rather than the standard of care surgeries?
All right. So these are a lot of tricky questions, again, because it depends. So in general, we do not recommend enucleation as a primary resection method for pancreatic neuroendocrine tumors that are greater than 2 centimeters in size. Those are a little bit more aggressive. They definitely have a higher propensity for metastasis to either lymph nodes or distantly. And so typically the recommendation there is a formal pancreatic resection with a regional lymphadenectomy to treat that disease. However, for small non-functional neuroendocrine tumors or for benign functional neuroendocrine tumors, the most common one of which is an insulinoma, which is an insulin-producing PNET, enucleation may be a good option. And so the nuances here are, one, it depends on the location of the tumor within the pancreas. So the pancreatic duct sort of runs through the very central portion of the pancreas. That duct carries all of the enzymes that are needed to help us digest our food so that we can absorb them. Tumors that are really close to the pancreatic duct are not really amenable to enucleation because of the risk of injury to the pancreatic duct. And a pancreatic duct injury or a pancreatic leak, which some of you have heard of, is really associated with significant morbidity and sometimes death. And so we usually will determine the distance of a small tumor from the pancreatic duct. We want enough of a distance where we feel that we can safely take the tumor out without damaging the duct. And so enucleation for small lesions, especially those, 1.5 centimeters or less, especially if it's in like a place like the head of the pancreas where we'd have to do a really big resection, enucleation may be an option there. Hopefully that helps. And then also there's always caveats. For some patients who may need preservation of parenchyma or have other reasons why they couldn't tolerate a formal resection, sometimes a decision is made to do a less oncologically optimal surgery to preserve quality of life. But again, I think all of these discussions are quite nuanced, and it really depends on your tumor and its location.
Right. I mean, hearing your answers really highlights the value of seeing a net expert.
Absolutely.
Thank you, Dr. Clark. Dr. Malak, there's an excellent question about scanning what's the best scan to find net tumors in the bones, skull, and brain? So on the PET dotatate, the orders say base of the skull to mid-thigh. So is MRI brain the best for skull and brain lesions?
Yeah, so osseous lesions, the important thing to know is that they could be most of the time occult on CT. So a lot of times until they've been present there for a long time, we see no changes on CT. So that's why a lot of times when we do dotatate PET, we see these lesions for the first time on the dotatate PET because they were not visible on the CT before. So MRI is a good option to see bone lesions, even those that are not really visible by CT, but we typically don't do MRI for the whole body. So MRI is more of a problem-solving tool or like a follow-up tool for the liver. And so we do it for dedicated regions in the bones if we need a problem-solving tool for a certain bone area. So dotatate PET is really the best option to look at bone disease and to follow up the bone disease over time, because on CT we would be missing the majority of them. So although the order says like typically base of skull to mid-thighs, I think most of the time people go to the top of the top of the head. For these scans, that's what we do at our institution. So for the skull lesions, a dotatate PET would show them really well. For the brain, the best tool to evaluate the brain well is MRI, because it would show us the metastatic lesions, and it would show us if there are any problems that are caused by these metastatic lesions. So if there's any compression, which area of the brain exactly, follow up the size exactly over time. So brain, if there is suspected metastatic disease to the brain, MRI is really the best tool.
And you emphasize the importance of contrast with the liver. How would you do it with the brain and bones?
Yeah, so for the liver, we do multi-phase imaging, and it is for the liver on CT, it has to be said on the order that basically we need multi-phase imaging. So we need to know that it is for neuroendocrine tumor to do multi-phase imaging. But MRI, the standard with MRI is to do multi-phase imaging. So a standard IV contrast could be used for the liver, but Eovist, which is the hepatobiliary specific agent, is superior to the standard IV contrast for the liver. But this is really hepatospecific. So it is not used for other organs. For other organs, if we're looking at the bones or we're looking at the brain, then it is with standard IV contrast, which is typically Gadavist in the US.
Thank you so much. I think we could keep talking for hours, but I'm going to welcome Josh Mailman back with the second panelist who will turn on their cameras and answer further questions. Thank you so much, Dr. Rivera, Clark, Ahmed, and Malak.
Dr. Chandrika, one of the questions that has come up here is, does it make any sense, or when would you hold off starting lanreotide? And is there any benefit, I know one of your mentors, to pausing somatostatin analog treatment?
Yeah, I think definitely this is one type of cancer that is, it's possible based on the patient symptoms that, or lack of symptoms, I would say, to observe and watch without being on octreotide or lanreotide. A typical scenario is probably a patient whose tumor is not making the hormones that cause the diarrhea, the flushing, because in those patients, if they're making any kind of hormone symptoms, in order to control the symptoms, we have to initiate the drug to control the hormone secretion. But in a patient who's not having any of these symptoms from the hormone secretion, where the cancer is just present, and it's not a high volume or high burden of cancer, it is reasonable in those patients to have a balanced discussion, again, in a case-by-case basis, to see if it is okay to watch these patients with imaging repeated. Now, we know the natural history of the tumor is to start growing at some point. I think one of the harder questions for me as a doctor is some patients like, when do I start it? Is it like at this percent of tumor or that percent of tumor? I think that is kind of a little, there's no clear definition of this is the time to start the drug. I often tell patients, if I'm seeing every scan with a little bit of growth, maybe it is time to consider starting a treatment like octreotide or lanreotide as a first step. Do we stop it? I think the same question. I do give the option of for some patients, especially who don't have the symptoms or the hormone symptoms. I tell them you don't have to live your life around every 4 weeks. If you have a trip, you have a vacation, and you miss your shot by a week here and there, it's going to be okay. So at least have that freedom, or know that you have that freedom. You don't have to do that every 4 weeks if your symptoms are not a problem.
Thank you so much. Dr. Mitra, bone mets are obviously challenging for all, and often we get the question on, can PRRT or LU-177 DOTA be effective against bone mets? And what do we worry about with using radioactive ligand with someone who has a bone met?
Yeah, good question. So, the nice thing about our targeted therapies is that as long as there's somatostatin receptor expression, no matter where in the body the disease is located, it will target that area and deliver the radiation. And so bone mets are a great example of that, where, we were talking about a little while ago, Dr. Malak was mentioning that dotatate PET is a great way to visualize those tumors. And so in the same way, it's a good way to treat those areas of disease as well. And generally speaking, a PRRT works pretty much as well as it does in other areas of the body, meaning that many patients will have a small reduction, many patients will have stable disease of their bone mets. And the other good thing is that it doesn't tend to cause any downsides. You might think that if you do have a lot of bone mets and you're delivering a lot of radiation to the area, you might have toxicity from that. But multiple studies have shown that that's not necessarily the case. So it's actually quite safe, and it works as well as it does for other areas in the body. The only caveat to that would be, again, if there isn't high expression of somatostatin receptors, then those areas wouldn't be targeted.
Great. Thank you so much for that answer. One of the things that the upregulation or change in tumor grade and between well-differentiated and poorly differentiated. So do we think that happens where we will get a grade change between, and does it really matter if it's well-differentiated and it changes from grade 1 to grade 2? And then how often do we see this going from a well-differentiated to a poorly differentiated, where we're seeing a neck go to a neck? And Dr. Thor, I'll start there with you to get you into the action here.
I guess the first question is, how often do well-differentiated neuroendocrine tumors change to poorly differentiated, much more aggressive neuroendocrine tumors? And honestly, I don't think we really know. I don't think it's very common. And whether a tumor is a grade 1, let's say, and the primary tumor is grade 1 or grade 2 or grade 3 in the liver, I am not sure that necessarily means that the tumor has changed the grade. It's just that sometimes the grade is a little bit higher at the metastatic site. But what really matters is that the poorly differentiated neuroendocrine carcinomas are treated very, very differently from well-differentiated neuroendocrine tumors. And I think the question isn't really settled in someone who has had well-differentiated neuroendocrine tumor and then gets diagnosed with poorly differentiated neuroendocrine carcinoma. We don't really know with certainty if the tumor changed from well-differentiated to poorly differentiated, or you just have a new poorly differentiated tumor. So there's a lot of work that needs to be done there, but the treatments are very, very different for those two different entities.
So I'm going to ask a few follow-ups to that. Our panelists discussed that, grade 1 well-differentiated, this is a very slow-growing disease, but why don't we have these slow-growing disease metastasize? How come they spread and do that? If they're slow-growing grade 1, why aren't they something else to do that? Dr. Chandrika, I'll go to you on that one, because it's kind of confusing, right? You get something, you're told this is wonderfully slow-growing, and then you have metastatic disease that Dr. Ganji has to take out all of a sudden.
Well, slow growing doesn't mean it won't spread. It just means it's slow growing. So I think the potential to get out by lymph or blood or the traditional pathways of other cancers spread is still, and I think that's kind of why we like to not use the benign terminology anymore with these cancers. The benign carcinoid implies that it may not spread, but I think all netologists are now careful not to use the word as much as possible. Because yes, slow growing doesn't imply it doesn't spread. Now, having spread, it can still be slow growing, which are two different things. And the potential to metastasize or spread is still remains.
Along this different thing between grade 1, grade 2, and well-differentiated and poorly differentiated, there's also a question of if you're non-symptomatic, can you become symptomatic later in the course of disease? And as someone who has, I'll already preface that answer as I know it's possible, but how often does it happen?
I think the question could be two. I mean, if I'm taking a stab at this one, there could be two ways when you say symptoms again, right? Do patients become symptomatic as the tumor grows from the bulk of the tumor? That can be possible. Can they become symptomatic because the tumor in the belly cavity, like the mesentery or the belly space where the bowel can twist and turn and groan and growl and things like that? That can happen. I think the other way to answer the question is it a tumor that's not ever made hormones start making hormones? I think that's the question.
That's probably
Yeah, I think I don't know if there's any literature research, but I would say the answer is yes. I definitely have as a clinician seen that instances sometimes where what was called a pancreatic neuroendocrine tumor non-functional did suddenly start having symptoms, and a couple of patients I remember turned out to be insulin secreting. I think the other way is also common. What used to secrete and then you took it out or did something and then they grow but don't always secrete. That's actually more common, specifically when you're speaking of insulinomas or insulin or even VIPoma, a couple of patients. I can tell you they don't always necessarily, when the tumor grows, start secreting or hit the threshold. It's also possibly because we're watching them so closely that we intervene before they hit the symptom. That's another reason. Maybe there's a bias there.
Thank you for that. And Dr. Ganji, I have a few for you. Tumor board, kind of interesting things. As a patient, you get a recommendation and as either the treating physician, you're giving that recommendation over. But to what extent do patients have control over their treatments? For instance, you're offering surgery, but they're interested in PRRT, or you see that they want PRRT, but your tumor board and your groups decides they should have something different. How well does a patient have control, or how do you work with that, and so that the patient and the physician are working together coherently?
Thank you for that question. I think the challenge with neuroendocrine tumors is that no two patients are really alike, and we don't have a perfect algorithm in terms of how you should treat everyone. So that's kind of typically how I'll start having the conversation with the patient. So not all metastatic patients are the same. Your pattern of disease might not be the same. Your eligibility for different therapies might not be the same. So typically I try to provide them with the different options that might be available, which might include systemic therapies, including PRRT, liver-directed therapies, which include surgery, et cetera, and kind of give them the potential risk and benefit of any of those therapies that might be available to them. And then typically what happens in a tumor board setting is we essentially have that discussion with the other parties involved, similar to if we were to have a discussion about a patient right now. I think we have everyone that we would need to at least make some important decisions, and then everyone kind of weighs in terms of saying, these are the best options that we have available for said patient. And if collectively we think that surgery might be the next best step for the patient, then we would present the patient with that option. But they may absolutely have no interest in going under the knife and having a metastatectomy or surgery, in which case we would provide them with the next best option and then get them involved with those particular physicians who would manage that aspect so that they can have a conversation. And then ultimately, we're not going to hold you down and operate on you if you don't want that. We're not going to hold you down and give you chemo if you don't want that. But at the end of the day, we, I think, collectively try to give you our opinion regarding what the next best therapy would be for you.
We've had, interesting conversation on histotripsy, and there are other advancements going on throughout medicine and throughout oncology. One of the questions here that one of the participants asked is there going to be less invasive type Whipple surgeries coming back using either robotics or some new type of technology that we may not be aware of yet? I know there's certainly new things with targeting at SBRT and various different things, but is there something else new, or is there always something new coming in the surgical field to make these less invasive and easier to recover from?
I think there's always something new on the horizon. Certainly robotics has made the surgery a little bit less invasive in terms of just sheer incision size and maybe earlier return to kind of function in terms of going home sooner, et cetera, but there's been no significant benefit in terms of oncologic outcomes with respect to the way that the surgery is performed. But I don't know of anything on the horizon at present that would make Whipple surgery less invasive necessarily, but certainly we are trying to find ways to just manage patients with other modalities other than surgery in general, I would say.
Thank you very much for that answer. One of the questions as an advocate who reviews clinical trials is, how do we reduce the number of biopsies that we do? But at the same time, there are reasons to have repeat biopsies. And when do you send them back to OR or IR to get a biopsy again?
So I can start there. So I firmly believe that we should repeat biopsies in a lot of our patients. And really, if there's a change in the trajectory of the disease, something that has been slowly growing, slowly expanding at the same rate, all of a sudden one of the lesions takes a jump and like doubles in size. And this happens much more commonly in pancreatic NETs or than small bowel NETs, and probably with some frequency in lung NETs. And that's actually where there might have been a transformation of a well-differentiated, slower-growing tumor to a poorly differentiated, high-grade tumor. And this is where we should biopsy again. And this is where we should actually do genetic testing on the tumors because a lot of times there might be new mutations. There might be something we can target with some of the newer therapies that we have. So that's my take on it. And for Chandrika, I'm not sure if you want to chime in.
Yeah, I'm a firm believer in the repeat biopsy, but I can play the devil's advocate too for the patients who don't like it, and give the other side, the other option. I think the only way we learn about these changes is by doing the biopsy, so we can get tissue to learn about it. But for patients who don't want an invasive method of, and if they have a personal preference or don't want to do it, I think, there are other situations. For example, Dr. Mitra has these nice two kinds of PET scans. We call them dual PETs, which, get the gallium PET or the FDG PET. These are ways to learn non-invasively, but I don't think they still replace the biopsy personally, because we have to know the genetic code of the tumor or learn about it. In fact, patients teach us. So this is another great time when, patients are the ones that move the field forward more than us. So I am a big repeat biopsier. Yes.
If I could just add to that, yeah, I'm glad you said that. I was going to say the same thing, is that when things start behaving differently, as was mentioned by Thor, but also if suddenly on imaging you see something different, an area that's growing on conventional imaging but suddenly doesn't show dotatate uptake, that would signify that maybe the behavior has changed and you might want to biopsy that. That's a very common thing.
Thank you for all those answers. All of you work in clinical trial research, which is fantastic, and I want to thank you for doing that. But the whole question of not just for alpha or PRRT, but what are the right trials with so many trials? I mean, I've been working on a clinical trial tool that LACNETS has on their site that tries to do a guided tour, so to speak, a guided method, but it still leaves you with 8 choices. How do you help your patients work through that?
I think to participate in a trial or not is already a first question. Standard of care option also available to you. So that becomes a big question. That's probably the hardest one to guide a patient through, because on one hand, we can put a clinician's hat and say, gosh, clinical trial is the way to answer a question. But I'm sure it's very scary as a patient to think about a clinical trial, maybe, and so that's probably one decision. And then specifically with respect to alpha therapy trials, the reality is, some of these trial criteria, a lot of patients, unfortunately, do get eliminated based on the specific criteria, whether that's the kidney function cutoffs we use for these studies, or the amount of radioactive dose that was delivered in your prior lutetium, for example, or any of those side effects. So in reality, I find it very few patients actually qualify for multiple trials. And then, of course, everybody knows the shortage of the radioactive isotope is also limiting, the ability to get on these trials and get going on the treatment part. So I think some of those situations, we have to tell the patient that, hey, this is what's best and needed for you clinically at this time. You could wait for a trial that may not ever materialize in time for you. And that could also be helpful in making those decisions.
Yeah, I would agree with all those comments. First and foremost are the eligibility criteria for each of the clinical trials is very strict. So you have to, meet those criteria. And as Dr. Chandrika said, it's always kind of very challenging sometimes to do that. Once you have a narrow group of trials, then within that, I think it's just kind of nuanced in terms of what is the best option for that particular patient. And also some of those other factors, such as, what the study requires and the distance to travel, and all these kind of like other factors come into play as well. So
yeah, the only thing I would like to add is that when we at our centers open clinical trials, that may be like only a third of the trials that we look at, because we don't open each and every trial we see. We really open trials that we think have like a meaningful impact. And often trials where both arms of the trials or all arms get active therapy. So there's a lot of thinking that goes into activating a trial at any medical center. So once it's open, it's a good trial.
So, Dr. Mitra, one of the things that comes off often, that Lutathera or PRRT causes mild dysplastic syndrome. And I think the last numbers I read were in the 2% range for those who may not have been heavily pretreated. How do you address that with other chemotherapy drugs that may have the same kind of percentage of MDS. And so how do you address that in the population, and do you compare to other drugs?
Sure. Yeah. So it's always is something of concern that gets brought up in our discussions with the patients and within ourselves. I would say, the 2% number seems to be pretty accurate for patients, as you said, who haven't been heavily pretreated with other therapies. And so it's ultimately something that's there, but it's a low risk. So we have to kind of balance what the immediate benefits of the PRRT will be for now and into the future compared to what that relative risk is. I think given the studies that are showing, the pretreatment factor that you mentioned, then that might actually kind of lead you to consider doing PRRT, earlier in the algorithm rather than waiting until many other options have been given, and then that raises the risk. But it's certainly a discussion that we have in our tumor board setting, to try to sequence these things because there aren't, really great answers out there.
So I will add to this that I think ultimately we're going to get better predictors of the MDS and leukemia risk, and there are some studies looking at that right now. And I will also echo what others have said. The risk is probably 2 to 3% if you haven't really had chemotherapy. It might be a little bit higher if you've had chemotherapy before, or if you get chemotherapy later. And also keep in mind that these are really effective treatments, and a lot of times there is really nothing else that you have in your toolbox that compares to this in terms of efficacy. So sometimes, unfortunately, we have to accept that small risk just to get that major efficacy.
I was going to flip and say, asking the patients their view on this would actually be more interesting as a collective, question, because the statistics, at least for lutetium, is out there, and so and then the question of whether the drugs temozolomide adds to it or not adding to it is still kind of, I think, unsettled, I would say. So I've found that in patients while counseling, it's a very different response, different times, so some of the younger patients tend to be a little bit more shy of the upfront PRRT approach because of this risk of leukemia. But again, it's very variable. I think a patient input would be very helpful here.
Yeah, I mean, I think it's a couple different ways, right? We have the ControlNet study that certainly showed combining them might be problematic and raise that to 8%, but sequencing them, that's a different question. But I think what I was trying to get at more is that when you go to, and I'm not comparing Lutathera and Captem to walking to a grocery store and buying a box of cereal and looking at the nutrition label and know that they are comparing the same exact things. But often patients are comparing different sets of numbers and won't have that comparison for the other drug that they're looking at. And it's almost like we need a nutrition label to make sure that we're comparing apples to apples, because what I see a lot of the time with my nuclear medicine colleagues is they're defending something that doesn't necessarily require defending in other scenarios, or the patient doesn't know what the MDS statistic for the other options that they have, and that we're not really giving a patient really good information to make that decision. We know this because it got highlighted, but we don't necessarily know it on all the drugs we take, which is a challenge. So I'll change gears just a little bit. And I know we talk about tumor markers from time to time, but any movement on working or validating ctDNA or other markers that might be more specific to disease progression?
So I can start maybe with the tumor markers in general. So there, just by saying that there's no perfect marker, and all of them have their limitations. And so a couple of things I'd like to mention. So I think for the high-grade, poorly differentiated neuroendocrine carcinoma, the circulating tumor DNA probably is beneficial. So you may pick up mutations and alterations on what's called a liquid biopsy that you will not pick up in solid tumor biopsies. So now I'm starting to combine those two. There are some published data on that. And the other thing I wanted to throw out there, which is not yet ready, in my opinion, for routine use, is a test predictive of PRRT efficacy called PPQ. It's sort of a version of the NET test that some of you are familiar with. So I think very interesting results. So there might be a blood test that predicts efficacy, but I think it really needs to be built into clinical trials. We need to put it to the test and validate it. I'm not saying it's ready for use yet.
I can add, I think I would agree. It being evaluated prospectively, that's good news. At least we'll have the answers, maybe, whether it'll be a good tool in the future. This time, we're kind of limited. Are there other things? ctDNA has the circulating tumor DNA has definitely an advantage, but its role in the low-grade tumors is unclear because they're not, I think, big shedders, and I don't get any information that adds to value right now in practice.
One of the really big patient challenge right now is sequencing. And does one type of therapy preclude another type of therapy? What are the roadblocks? The question that came up specifically was, can someone have surgery post-PRRT? Is there anything about PRRT that makes this surgery more challenging? And, what we worry about most is limiting our options. Because as a patient, that is probably one of the things I am most concerned about. What am I closing off that I may not be able to get? And I'll start with the surgery question with you, Dr. Ganji, and then I'll open it up to everyone else to conclude.
Yeah, again, I think this is I'm going to make a broad statement that may not be applicable across the board, but so the sequencing may sometimes impact your eligibility for surgery, but it depends on why that particular sequence of therapies was chosen. So sometimes we want to do something to downgrade a tumor to see if we can shrink it to make surgery more feasible, or to preserve more liver, or preserve more of the mesentery if we're taking the pancreas, or to get it off the small bowel, or to get it off the vessels if we're looking at a pancreatic tumor. Alternatively, if you're not eligible for surgery at the outset, a lot of those therapies might be your only option. And if you have adequate shrinkage, then sometimes you all of a sudden become eligible for surgery. So I think it's impossible to kind of generalize that statement. Sometimes the therapy that you may have had can make surgery more difficult. So sometimes if you have liver embolization or Y90 or other things, and you're needing a big resection and we have to come around the vessels, we typically will see more fibrosis and things of that variety, which can make it more challenging, but not impossible. Similarly, we see more of this kind of fibrotic desmoplastic reaction in small bowel tumors within the mesentery, with some foreshortening of the mesentery after PRRT. Again, it doesn't necessarily preclude you from having surgery, but it can sometimes make it more complicated. So I think it's something to consider, and an important question when you're making a decision as a patient in terms of what sequence of treatment you want to have. It's an important question to ask in terms of what your eligibility is now and what it might be in the future, but it doesn't necessarily take it off the table entirely.
That was a great answer, Dr. Ganji, by the way. Thank you.
I always explain to the patient as, go down a path and imagine the best case scenario and the worst case scenarios. When you're at a crossroad having to make a decision versus, say, surgery or a drug therapy or a PRRT, do the exercise with your physician, with your team of, hey, what if I go through surgery? What's the good outcome? And then, which nobody likes to talk about, is what is not the good outcome. And then go down that path further and say what happens. That exercise helps that answer, I think, Josh, a little bit, to know what could be closed off. And I think the real question about sequencing is still a little bit of a challenge for even clinicians. Especially when it comes to like PRRT and CAPE-TEM or some kind of a very effective treatment, and you have a very symptomatic patient in front of you, and which one do we use? I think that's the question that's hard for me to answer, but for the patient, I always say walk down the path and do that exercise.
I think with sequencing of systemic therapy or the drug therapy, for most part, using one treatment doesn't preclude the use of another treatment later, with the exception of some clinical trials. So, for example, one of the alpha particle trials now really only allows patients with previous lutetium therapy. Another alpha particle trial doesn't allow any prior therapy. So that's actually where we might have to think a little bit about the sequencing. But for the available treatments, really not a big deal, but more about side effects, efficacy, and things of that nature.
So I really want to thank this panel. It's been wonderful to be here for the last half hour with all of you, and our first panel as well, and Lisa for having me come on, and LACNETS for putting this on. And with that, I will turn this over to the studio and let them go for concluding remarks.